that is 50 minus 10 is 40, divided by the QS, that is the cardiac output, which is 5 liters per minute. This is without shunt lesion. So it is 8 units. Now, when we talk about the pulmonary vascular resistance index, which is important in pediatric population, instead of this QP or the cardiac output, use cardiac index. Cardiac index is 5 by 1.5. So 40 by, so 50 minus 10 divided by 5 by 15. This is the cardiac index. And in arithmetics, this will go as the numerator. So that is how you got the index as the resistance into body surface area. This is the way by which that calculation is got, which some of the students are not familiar. So instead of this resistance, you use, instead of the cardiac output as the denominator, the cardiac output as the denominator, here you use cardiac index as the denominator, which is 5 by 15. And when it comes, this will go up. That is pure arithmetics or whatever it is. So PVR or SVR is the resistance into body surface area. Okay. Now, once you know this thing, next is the normal values. I think you go through the textbook. There is no point in reading all those things. You can take a standard textbook and copy these things. I talk to all the postgraduates. If they have a notebook, in the front page, you have to write all these pressures, because empty numerous times, even the senior postgraduates, many times they fail to say what is the normal pressure forms. They may talk about the LV systolic and diastolic, PA systolic and diastolic, but it comes to the atrial pressures, AV, VV, they fumble. So this I am not teaching. They should know this. Okay. Now, this is one thing which you should know. That is, in diastole, the pulmonary valve is closed, the aortic valve is closed. The mitral valve is open. There is no obstruction in between. That in diastole, the pulmonary valve is closed, aortic valve is closed. From the pulmonary artery through the capillaries to pulmonary vein, LA, LV, there is no obstruction. So the diastolic pressures in these chambers, this circuit is same unless there is an obstruction. So the LV diastolic pressure equals the LA mean pressure, equals the pulmonary venous mean pressure, equals the pulmonary capillary mean pressure, equals the pulmonary artery diastolic pressure, with 1 to 2 millimeters rise as you go proximally. That is all. This is very, very important. Now I will give you an example. Here is a 30-year-old lady, class 3 dyspnea. The pressures, aortic, LV, all those things I have written. Now I will read for the students. Aortic, 120 by 60, mean 80. Is it normal or not? Many times they say it is normal. But in hemodynamics, the pulse pressure is white. The diastolic pressure is on the lower side. Keep it in mind. You have to think with the clinical background, is there any situation for a white pulse pressure? With the clinical background. Sometimes it could be normal. It may be an error in hemodynamics. Then coming to LV, it is 125/8. It seems to be normal. Compare with the chamber to which it is communicating. That is, the flow is communicating, because LV is communicating to aorta in systole. The pressures are almost the same. It is not communicating to the aorta in diastole, so don't try to compare that. Now coming to LA, or pulmonary artery wedge is LA, 820/24, mean 18. Obviously it is high. The waveform is maintained. Now you compare this. The pulmonary vein or the left atrium communicate with the LV in diastole. So compare the mean pressure with the LV diastolic pressure. You find there is a gradient of 10 millimeters of mercury. That means there is an LV inflow obstruction. Now magnitude, we take so many background to say that is moderate or severe based on the heart rate, so many other things. Now coming to pulmonary artery, it is 70/30. Obviously it is high. Systolic is high. Diastolic is high. Mean is high. So definitely there is pulmonary hypertension. So you have to compare the pulmonary artery with the distal chamber, that is in diastole. I told you that in diastole it is communicating freely. So here is 30, here it is 18. So there is a diastolic gradient of 12 millimeters. and a mean gradient of 27 millimeters of mercury. So you find that there is a transpulmonary gradient of 27 millimeters and a diastolic gradient of 12 millimeters. Is it clear? Okay. Now coming to the RV, 80 by 10. So you find that in systole you have to compare with the PA. 10 millimeters difference is acceptable. In diastole, it is 10. We don't compare with PA. But this pressure is a little higher than normal. So you have to say that there is RV systolic hypertension with probably RV dysfunction. Coming to RA, A16, V24, mean 14. So pressure is high. Okay. Then the V is taller than the A. Normally A is taller than the V. So we should look for causes of prominent VV. Okay. And compare the RA pressure with the RV diastolic pressure. Now you find there is a 4 millimeter difference. Can you see my arrows moving? Can you see my pointers moving?
Yes, sir.
Okay, fine. So you can see that there is a gradient of 4 millimeters. Now you have found there is a wide pulse pressure. There is a diastolic gradient across the LV inflow. There is pulmonary artery gradients with a mean grade pulmonary artery hypertension with a transpulmonary gradient of 27 millimeters and a diastolic gradient of 12 millimeters of mercury. There is RV systolic hypertension with RV diastolic pressure elevation. There is a prominent V wave with a high RA pressure and a gradient. So there is a mitral LV inflow gradient, RV inflow gradient, and pulmonary hypertension. So you have mitral stenosis, diastolic, there is pulse pressure, you have to think of AR, pulmonary hypertension, then RV dysfunction, and a gradient that is tricuspid stenosis with prominent VV. So these are the conclusions which you have to draw from this. Now you have the saturations. I will go to the next slide. Okay. Now we try to calculate the case, cardiac output, oxygen consumption in ml per minute, 180. That is VO2 is 180. Then arteriovenous content difference, hemoglobin in gram per liter, 15 gram per deciliter is 150 gram in liter into 1.36. That is the oxygen which can be carried if it is 100% saturated into 30%, 30 by 100. So oxygen consumption body divided by the oxygen content, hemoglobin in liters. That is 15 gram in 100 ml is 150 gram in 1 liter into 1 gram of hemoglobin can carry 1.36 ml of oxygen. So there is oxygen content. I have excluded that PaO2. And the difference is 30%. So 30 by 100. This 100 will go and it will come as 3 liters per minute. So cardiac output is 3 liters per minute. Okay. Now the resistance. You have found that the PVR is pulmonary artery mean is 45. The pulmonary artery wedge is 18. That is the difference, 27 divided by 3. That is 9 Wood units. Normally is 1 to 3. Transpulmonary gradient. It is pulmonary artery mean, that is 45, minus the pulmonary artery wedge mean is 18. That is 27 millimeters. Normally it is less than 12. And diastolic pulmonary gradient. That is PA diastolic is 30 minus pulmonary artery wedge mean is 18. 30 minus 18 is 12. Normally is less than 7. This value is very important. Just as what is the type of PAH? Type of PAH. Okay. The type of PAH, when the mean pulmonary artery pressure at rest is more than 25 millimeters of mercury, some people now put it as 20, especially when it is coming to idiopathic PAH. If the pulmonary capillary bed pressure is less than 15, left heart is normal, so it is pre-capillary. If it is more than 15, it is post-capillary. Now, is it purely post-capillary passive? You look at the PVR should be less than 13, the transpulmonary gradient should be less than 12, and diastolic pulmonary gradient should be less than 7. Then you can say it is purely passive pulmonary hypertension. In a patient with mitral stenosis, has the pulmonary vasculature reacted In that case, the pulmonary vascular resistance will be more than 3 Wood units, the transpulmonary gradient will be more than 10, 12 units, and the diastolic gradient is 7 millimeters more, indicating that there is a resistance at the pre-capillary level also. So this is a post-capillary with a reactive or disproportionate PAH. Okay, this is simple. I think I will not go to that. I can skip that. And now I'll come to a congenital heart disease. Okay, this is a 22-year-old female. Okay, this is the oxygen saturation 96 iota, right atrium is 53, PA is 91, pulmonary vein is 97. Okay, the pressures, this I have taken only for calculations. Okay, pressures PA 85 by 25 mean of 50, pulmonary vein mean of 10, oxygen consumption 18 and hemoglobin 18. Now how will you calculate the QP by QS? You can calculate the flows and ratios can be calculated because the oxygen consumption is a constant. You take this, the reverse of that is systemic arteriovenous difference divided by the pulmonary arteriovenous difference. Systemic is aortic minus right atrium, 53, that is 43. The pulmonary is pulmonary arterial minus this difference between the pulmonary artery and the pulmonary vein, it is 6. So 7:1. That is the QP by QS. That is the ratio. Left right shunt is 7:1. Now, how can you calculate the QP? The oxygen consumption divided by the pulmonary arteriovenous oxygen content difference. Similar to that, 180 minus 150 into 1.36. That is 15 gram is 150 gram in 1 liter into 1.36. And what is the pulmonary arteriovenous difference is 6%. So 6 by 100, which will come to 14.7. Similarly, you can calculate the systemic blood flow. Instead of this pulmonary arteriovenous oxygen content difference, you have to say aortic minus right atrium. It is, you have to take that difference and calculate. Now, this patient has pulmonary arterial hypertension. Obvious. Now, the pulmonary arterial hypertension is pre-capillary because the post-capillary pulmonary venous pressure is normal. If this has been more than 15, you think of post-capillary also. So this is a pre-capillary pulmonary hypertension. Now you go for the PVR. Pulmonary artery mean pressure is 50 minus the pulmonary mean pressure minus the pulmonary vein. Okay, sorry. Okay, the pulmonary artery mean pressure minus the pulmonary vein pressure is 40. There is 50 minus 10 divided by the pulmonary blood flow, which is 14.7 units. It is 2.72. In adults, we need not bother very much about the index, but you can multiply it by the body surface area to get the PVRI. Okay, I'll take a few examples of oximetry. Now this is the oximetry, 2 samples. Just to illustrate a few examples only. Look for the pulmonary artery aortic saturation. That is my first step. Normally, pulmonary artery saturation is less than aortic. And suppose this is 70, the difference we have to calculate. Normal systemic AV difference or the arteriovenous oxygen difference is 20 to 25. If it is narrow, that means hyperdynamic circulation or left-right shunt. If it is wide, low cardiac output or right to left shunt or desaturated situation. So that is the first thing. Arteriovenous oxygen difference, it should be normal 20 to 25%. If it is more than 25%, that means the cardiac output is low or there is a right to left shunt or a desaturated situation. If it is very narrow, it means a hyperdynamic circulation or a left-right shunt. Now here you take, both are same. What are the situations where both are same? You have only 2 entities or 3 entities. Once both are same, look at the next proximal chambers. That is the left ventricle and the right ventricle. Here, those are also same. That is, both the great arteries and both the ventricles are the same. Next, you look, still the proximal chamber, right atrium and the left atrium. Now you find that aortic and PA are same, the ventricles are same, and the atria are same. That is same in both great vessels, same in great vessels and 2 ventricles, Same in all four chambers and the great arteries. Okay, that's very clear. Here you find the aortic is 70, pulmonary artery is 90. That is, pulmonary artery is greater than aortic. Okay, now I will tell the conditions. The conditions. One, pH saturation more than aortic. Classically, it is DTGA. Toxic big anomaly with physiologically is DTGA or TGA, the circulation. And minor increase in the pH saturation can occur in a supracardiac TAPVC. It's only 2 to 4%, nothing great. Both are equal. Both are equal. There is aorta and pulmonary artery is receiving blood from one great artery, atresia of either semilunar valves, commonly pulmonary atresia. Where both the ventricles will empty to the aorta, and that will provide blood to the pulmonary artery through AP collaterals or through ABT shunt or whatever it is. Truncus, theoretically, but there will be streamlining, so less likely to have equal saturation. But some examiners want truncus also to complete the list, but there will be streamlining, so it will not be equal. This will be equal in atresia. Then pulmonary artery, aortic, and two ventricles equal means the univentricular physiology. The whole blood, the systemic and pulmonary venous blood is received and mixed in the ventricles, and it is emptying to the great arteries. Classically, mitral atresia, tricuspid atresia, the commonest. Single ventricle, again like tricuspid atresia, by definition, it need not be that the two ventricles, that is, one ventricle is receiving the whole blood. More than 1.5 drainage can be taken as single ventricle physiology. So it may not be, but you can tell that as an answer. It is a univentricular physiology. Commonest is tricuspid atresia. Then you can take single ventricle of different types. Mitral atresia rare. Then equal saturation atria, ventricles, and great arteries. That is TAPVC. Okay, I will have the last slide. That is, you have that what is called is the transposition of great arteries. Students are not at all familiar, except very few students who have been trained in congenital heart disease, probably the pediatric fellows. This is transposition. You have the vena cava with the desaturated blood coming to the right heart and the pulmonary venous blood coming to the left heart. Then to survive, there should be intercirculatory mixing of almost equal volume. One region cannot be flooded. It should be balanced. So what happens is part of this venous blood will go to the left heart. So this is thing, and that will go to the pulmonary artery for oxygenation. Now let us take this. The saturated blood coming from the pulmonary vein to the left heart through a VSD or a ASD, whatever it is, part of it will go to the right side. So this is anatomical left-right shunt. That is, from the left it is going. It is saturated blood which is going from the left side to the right side. And that goes to the aorta. So that is the effective systemic blood flow. That is the oxygenated blood which crosses and goes to the tissues. That is the effective systemic blood flow. That is the anatomical left-right shunt is the effective systemic blood flow. And similarly, or on the other way, the venous blood coming to the right heart, part of it goes to the left heart. So it is an anatomical right to left shunt. And that will go to the pulmonary circuit for oxygenation. So it is the effective pulmonary blood flow. And there is oxygenated blood is going to the pulmonary arteries, the physiological left-right shunt. Left-right shunt means oxygenated blood is going to the lungs. So this one, C, is the physiological left-right shunt, but it is not anatomical. Anatomically, it is going straight. So this is the physiological left-right shunt. This blood, venous blood, which is going to the aorta, is the physiological right to left shunt. There is nothing anatomical. Vena cava to right atrium to right ventricle to, say, it is going to the aorta. Okay, so that is the physiological right to left shunt. Anatomically, it is straight going. There is no crossing. There is no crossing from left or right. Here we are talking about left, right, left, right. Anatomical and physiological. Then, so what is happening is the oxygenated blood on the left side crosses to the right side. So that is the anatomical left-right shunt. But that is oxygenated blood going to the aorta. That is the effective systemic blood flow, QES. Now, this remaining blood, which is going to the pulmonary circuit, is recirculating. That is, from the left heart, it is going to the pulmonary artery, means physiological left-right shunt. And the venous blood coming to the right heart goes to the left heart. So, anatomical left-right shunt, and that will go to the pulmonary artery for oxygenation. So, the effective pulmonary blood flow. This blood, which is going straight without any shunting anatomically going to the aorta, there is a venous blood going to the aorta, is the physiological right to left shunt. I think the juniors, the residents have to go through it again and again, because nobody is training you, teaching you. I think at least some of us are teaching you, but many times they are skipping these things. If I am the examiner, I may ask. Fortunately, I am not the examiner. I may ask this thing. I think I have taken 30 minutes or more than that.
Sir, could you show your saturation slide again?
The previous one?
No, the first one, the saturation. You have shown the saturation. I think 3 or 4 slides ago, 20th slide.
This one?
This one.
Yeah. Oximetry, I will take the previous one. I'm just putting at this, I think you can see. First is compare the aortic and pulmonary artery. That is the first thing. To look for artery-venous oxygen difference. In all situations, artery-venous oxygen difference is very important. Okay? Because even in microstenosis or any heart disease, we have to see what is the cardiac output. Roughly you get an idea. Hyperdynamic circulation, low output, high output, left-right shunt, all those things you get an idea. That is wide or narrow. Here it is same. Once it is same, look into the proximal chamber, that is the ventricles. Here, both great arteries and both ventricles same. Next, you go for still proximal, that is atria, ventricles, and great arteries. All are same. So the previous one, here it is the aorta and pulmonary artery is getting the blood from a common source, single source. So commonly it is pulmonary atresia, rarely aortic atresia because they seldom survive. Truncus arteriosus described, needed by the examiners, but it will not be same. There will be streamlining because anatomically the vessels are oriented. It is not like transposition. They are oriented normally so that the right ventricular blood is likely to go to the pulmonary artery and left ventricular blood is likely to be preferentially given to the aorta so that the saturation may not be same. Here, the ventricle has, the blood has mixed, the venous, systemic and pulmonary venous blood has mixed in the ventricles. So it's a univentricular physiology. That is not physiology, it's a univentricle. That is the single ventricle is functioning and receiving blood from both great atria. Classically it's bicuspid atresia because there the mixing occurs in the left ventricle. The right atrial blood and the left atrial blood comes to the left ventricle in diastole, it mixes. Then it empties to the aorta or through a VSD to the pulmonary artery, which is normally related great arteries. Mitral atresia, the same thing in the opposite direction. Single ventricle, I have some reservation because single ventricle by definition, I don't know, that is what I know. That is by definition, more than 1.5 AV valve drainage can be taken as a single ventricle physiology. It need not be that both the AV valves should completely drain. There will be a rudimentary ventricle also. Sometimes there may not be. Okay. Then if all the chambers are same, then obviously the mixing has occurred in the atria. Classically, TAPVC. Single atrium also, it is very unlikely, even though the examiners want that. But single atrium is like a large atrium. RV is more compliant. So what happens is, left atrial blood is preferentially likely to flow to right atrium, and right atrial blood will go to the right. So just like ASD, there will be some mixing, but it will not be same. Some examiners want single atrium also as the answer. Then once you have that TAPVC, then how to know if it is supracardiac, cardiac or infracardiac? To go for the venous saturation. If the superior vena cava shows a high saturation, it is supracardiac. If the IVC or the hepatic vein shows a very high saturation, it is infracardiac. If both are normal, but the A2 saturation is equal, that means it is intracardiac. I think you can contribute to these things. We have the other faculty also if time permits. Because Rao sir is there, Dr. Venu is there. I have a few more slides. I don't want to go beyond this now. Is it okay, Jabir?
8:15.
Yeah.
Jabir's presentation is also there. No?
Yeah. Okay. If
No,
the
I think you
students
can ask the postgraduates to send their queries in the chat box or